Hello everyone, I'm pleased to be here today virtually to talk to you all about our work using transcranial focused ultrasound in healthy adults. As a brief background, anxiety disorders are incredibly prevalent. 1 in 3 Americans will be diagnosed with an anxiety disorder in their lifetimes. We know from PET, fMRI, and lesioning studies that the amygdala is strongly implicated in anxiety disorders. Medications for anxiety, such as benzodiazepines, have side effects and addiction potential. As a result, many patients cannot or do not want to take them. Non-invasive brain stimulation techniques, such as rTMS, cannot stimulate deep enough to modulate the amygdala. This represents an opportune moment to demonstrate the clinical utility of low-intensity TFUS for treating anxiety disorders. Our study was a double-blind, crossover, counterbound study. Subjects came in for 2 visits, where they received MR-guided focused ultrasound stimulation of the amygdala on one session and the entorhinal cortex on the other. Subjects did not know which structure was sonicated on which session, and neither did the neuropsychologist performing the pre- and post-evaluations. We utilized the BrainSonics Pulsar 1002, which comes with 3 fixed focal length transducers. While all 3 have different focal lengths, they all have an active aperture diameter of 61 millimeters. The design of the BrainSonics system does not incorporate any ferromagnetic materials, which allows for the simultaneous acquisition of functional MR data during TFUS administration. Our ultrasound parameters utilized a 650 kHz fundamental frequency with a 10 Hz pulse repetition frequency during amygdalar sonication and a 100 Hz pulse repetition frequency during entorhinal cortex sonication. Both sonication paradigms utilized a 5% duty cycle with a D-rated ISPTA of 720 milliwatts per square centimeter. Subjects received 10 30-second sonications with a 30-second intersonication interval for both the amygdalar and the entorhinal cortex sonications. Both before and after each sonication session, subjects performed the IAPS-based emotion regulation task. Subjects were asked to either watch a negative image, view a neutral image, or reappraise a negative image. After viewing each image, subjects were asked to rate both the valence and the arousal of each image. We then generated indices of negative reactivity by subtracting the view from the watch ratings and of reappraisal by subtracting reappraise from the watch ratings for the valence, arousal, and skin conductance level. Here you'll see the effect sizes and the changes in these indices during amygdalar TFUS. In negative reactivity, amygdalar TFUS had a moderate effect size for skin conductance and a large effect size for arousal, suggesting that there is an increase in the skin conductance and arousal after sonication when viewing negative images. There was no effect for valence. On the reappraisal side, amygdalar TFUS had no effect on skin conductance level. Arousal had a large effect size, and valence had a moderate effect size, suggesting that there was decreased arousal and increased valence when reappraising negative images after sonication. This in total suggests that TFUS has the potential to downregulate amygdalar activity and thus has promise as a potential future treatment for anxiety disorders. I'd like to now thank my co-authors in the Buchheimer Lab, Monty Lab, Krask Lab, Sathana Lab, and other co-authors not currently affiliated with a lab. For more information on the entorhinal cortex behavioral and imaging findings, please see the talk by Taylor Kuhn. For the amygdalar imaging findings, please see the poster by Bianca Dang. Thank you.